We're going to be doing this very first SAGES live stream in the Foregut group. Today, we're going to be talking about esophageal motility, and we have a really great lineup. We're going to start with Rob Yates, who's one of my colleagues at the University of Washington, talking about interpretation of high-resolution manometry. Alex Rodriguez is going to talk about achalasia, and Leen Khaitan is going to talk about non-achalasia motility disorders. Just to set the stage, we're going to do fairly brief talks and then a few questions at the end, and then after each speaker, and then at the end we'll have a panel session. So put your comments and questions up on Facebook, and we'll try to get to them. And all of the authors or all the speakers are on Facebook, so even if you don't tune in live, we'll try to answer questions as they pop up. So I'm going to stop the screen share here and turn it over to you, Rob. Go ahead.
Great. Okay, I'm going to share my screen as well. And my presentation up here. Well, thanks very much to Andy for coordinating this, and thanks to everyone who has joined in live, and also to everyone who is going to watch this in the future, as we're going to have it recorded and available online as well. So I was asked to give a brief overview of approaching high resolution manometry. And so for the next 10 to 15 minutes, I'm hoping to give you an idea about how to approach these studies. My guess is that there's, in our audience now and in the future, there's going to be people with a broad range of experience with high resolution manometry. And so I'm hoping to give just a basic background on what high resolution manometry is and how to approach these studies when you're given a report. So I'm not going to go into a lot of detail. In fact, I'm not going to touch on at all on how to actually conduct the studies in the programs and that sort of thing. And but I do want to give some good background that'll give you a basic foundation to approach these studies. So if you break down manometry, esophageal manometry studies to their basic form, there's basically three pieces of information they give you, and it's all related to pressure as it relates to specific anatomic locations in the esophagus, from the upper esophageal sphincter through the esophageal body, down through the lower esophageal sphincter and the gastroesophageal junction, and that pressure in those anatomic positions over time. So if you break it down to the most basic three pieces of information, that's what it gives you. You may also see that impedance is included in some of these studies. That's a fourth piece of information that is included in some high-resolution manometry studies. And essentially, this is just measurement of the resistance to electrical conductivity in the esophagus, which really ultimately gives us information about clearance of the fluid bolus from the esophagus. I'll go into a little bit more about that in the coming slides. This information is acquired with a catheter, high-resolution manometry catheter. This example of a catheter, and the one that we use, has 36 different pressure sensors along its length. They're separated by 1 centimeter distances along the catheter. And they have both the pressure sensors and the impedance sensors pictured here in this blown up portion of the image. So it's 36 centimeters from the beginning of the pressure sensor down through the tip. These are inserted in the nose, essentially like a nasogastric tube. This is just two screenshots from a YouTube video that's available online showing how a high resolution manometry study is acquired. So this is how they're acquired in our lab as well. There's a workstation on wheels with the appropriate hardware and software loaded onto it. We have either a technician or a nurse in our lab who perform the studies, and they block about an hour of time to do that. The study itself, once the catheter is in and the patient's ready to go, takes about 15 minutes or so. But from the very beginning to the very end takes about an hour. The patient is seated here. They're in a sort of semi-recumbent position. You can see the catheter has already been placed. And then the core portion of these studies is acquired when the patient performs a liquid swallow with a saline solution. So it's 5 milliliters of a saline solution that the patient ingests They're asked to hold it in their mouth temporarily and then perform the swallow and swallow that. And then that information is acquired real time here on the software package. Once the study is complete, the technician in the lab then can make that available to whoever is actually going to interpret the study. And then, for example, so in our situation, we have our fellows, and Alex was our research fellow for a couple years and performed hundreds, if not maybe thousands of these studies, interpreted hundreds, if not thousands of these studies, and then can download the software or the information, the data into the software program and actually interpret that manometry study. The information that's gathered, I just want to give, this is a cartoon version, but the basic pattern of a swallow that you're going to see is an upward deflection in pressure in the pharynx, coupled with a downward deflection in pressure in the upper esophageal sphincter, and then followed by a series of positive pressure waves down the esophageal body. At the lower esophageal sphincter, you'll see that there's a resting pressure of the LES, and at the initiation of the swallow, the lower esophageal sphincter actually relaxes to allow for the fluid bolus to pass down into the stomach, and then you get a little compensatory increase in LES pressure after the swallow is complete. So that's the basic form of a swallow, again, portrayed here in a cartoon fashion. Prior to high-resolution manometry, we used to read, and it was actually before I started reading them, but they were read with this sort of an older-fashioned pressure wave reading. There were fewer pressure sensors along the catheters, but you can see that it's a similar pattern. So an upward deflection and pressure in the pharynx, relaxation of the upper esophageal sphincter, followed by a series of positive pressure waves through the esophageal body. And then you get this compensatory lowering in the lower esophageal pressure during the swallow to allow for the fluid bolus to pass. Going back to that concept that this is all just measurement of pressure, and I'm going to touch on this several different times throughout the presentation, but you can see these pressure waves at the lower esophageal sphincter. That's probably respiratory variation at the diaphragmatic crura as they pinch in on the esophagus. So every deflection pressure, whether it's positive or negative, reflects not necessarily esophageal function, but pressure on the catheter, the manometry catheter itself. And so you have to keep that in mind as you're looking at these studies. So that's probably a respiratory variation at the LES because of the diaphragmatic pressure on the catheter. High resolution manometry looks essentially like this. You have on the x-axis time, on the y-axis the anatomic location in the esophagus, beginning in the pharynx, going down through the upper esophageal sphincter, the esophageal body, and then the lower esophageal sphincter and into the stomach. So this is a basic normal appearing peristaltic swallow. The anatomy of that includes contraction up in the pharynx, relaxation of the upper esophageal sphincter, and then followed by a nice peristaltic swallow all the way down through the LES. The color represents pressure. So the highest pressure readings are in this magenta purple color, and the lowest pressure readings are in the dark blue. So you can see the upper esophageal sphincter, its resting pressure is quite high, and then when the swallow initiates, you have a relaxation, and as evidenced by the blue color there. So color is pressure, x-axis is time, y-axis is anatomic location on the esophagus. I mentioned before about impedance. Impedance is typically represented in high-resolution impedance manometry studies by this purple color. So the fluid bolus in the esophagus is represented by the purple. You can see that as the swallow progresses down through the esophageal body, that you actually have clearance of this liquid bolus from the esophageal body into the stomach down here. So after the swallow occurs, you have much less, if any at all, residual purple color, which is just representing the fluid bolus that was in the esophagus. To show you what this looks like in a manometry study where there's a couple of failed swallows. So you have initiation of the swallow here in the pharynx and the upper esophageal sphincter. And then you just basically have fluid that persists in the esophageal body, some clearance from the upper esophagus, maybe from that initial initiation of the swallow, but most of the bolus persists down here in the esophageal body because of the failed peristaltic swallow. So moving into, from the background into how can we use esophageal manometry, high resolution manometry to come up with a diagnosis. So about 15 years ago, the International High Resolution Manometry Working Group came up with a classification system that they termed the Chicago classification because the people who led this group were out of Chicago. And they basically said, well, how can we take this data and come up with diagnoses that we can generate from the data that we acquire from these studies. They're currently on the third version, that's the V3.0, third version of this classification system, which came out, I think it was back in about 2015. And I don't want you to get too caught up in all the information that's on here. I just want to point this out for two reasons. One is that this is the key flow chart that you can use to work through these studies once you understand the basic concepts that I'm going to talk about in the coming slides. And two, that all of these diagnoses, all of this information basically is comes down to understanding four main concepts or pieces of data that you can acquire from these high resolution manometry studies. So one from the lower esophageal sphincter and three from the esophageal body. So I'm going to talk about those in the coming slides so that then you have a good background or baseline understanding of these four concepts, four data points that then you can take back and use to come up with these diagnoses using the Chicago classification system. So for the lower esophageal sphincter, there's the integral relaxation pressure. The esophageal body, there's three different data points, including the distal contractile integral, the distal latency, and fragmentation. So the lower esophageal sphincter, you actually have two different pieces of information that's important, but one that's really used with the Chicago classification. So the first one is resting pressure. That's just the pressure that's exerted on the probe at rest at the LES. Relaxation pressure, this integral relaxation pressure, is the piece of information, the data point that you need to help with diagnosis using the Chicago classification. And that's the how well does the LES relax when a swallow is initiated or throughout the swallow process. So graphically, here you see the initiation of the swallow, relaxation of the upper esophageal sphincter, so that's where the swallow initiates. Down here, you can see the lower esophageal sphincter is at its resting pressure, and then with the initiation of the swallow, you have compensatory relaxation of the LES, and that's what the integral relaxation pressure actually measures. So from the beginning of the swallow through the end of the swallow, it actually looks at the 4 seconds during which the pressure is its lowest, and that's what the IRP is. But it's essentially a reflection of how well does the LES relax during swallowing. In this slide, you see the normal LES resting pressure. So there's a normal lower esophageal sphincter resting pressure. However, the IRP is actually elevated, and you can tell that because graphically, when there's initiation of a swallow, you really don't see any compensatory relaxation in the lower esophageal sphincter. So you see persistent high pressure throughout that swallow, a lack of relaxation. And this gives us the diagnosis. And I don't want to get tied up in a lot of the diagnoses because I know Lena and Alex are going to talk about this in their presentations, but this gives us the diagnosis of esophagogastric outflow obstruction. And I bring this up because it's probably the most commonly commented on diagnosis that we put in our reports. Referring physicians, referring providers, and patients, in fact, when they get their reports, they say, well, what's this esophagogastric outflow obstruction? And what I can say is frequently we see this, but it doesn't necessarily mean that it doesn't necessarily correlate with patient's symptoms. So you say, well, are you swallowing okay? Do you ever have any dysphagia? Ever any food caught, liquids caught? And frequently the answer is no. And not only does it not correlate necessarily with symptoms, but if you look at the impedance, it doesn't necessarily correlate with port bolus clearance. So this is the same study that I show in the background, but with impedance overlapping the manometry information, and you can see that the the bolus is actually cleared pretty effectively from the esophageal body, despite having this diagnosis of esophagogastric outflow obstruction. So I wanted to make that point. You do see a little bit of persistent fluid bolus, and that comes right at this transition zone, which I'm going to talk about in a few slides. Another concept that we see, as it relates to the lower esophageal sphincter, is a concept of dual high pressure zone. Essentially, this represents a hiatal hernia that's present in the patient who's undergoing the study. So in the normal anatomy on the left side of the screen, the diaphragmatic cruce, which I mentioned a few slides ago, in terms of the pressure that you see exerted during the respiratory cycle, is lined up with the lower esophageal sphincter. So you have the diaphragmatic cruce and the lower esophageal sphincter lined up in the normal anatomic situation there. And that's represented manometrically, where you have essentially a single line of pressure across at the level of the gastroesophageal junction, the lower esophageal sphincter. You do see a little bit of higher pressure here. That's the respiratory variation, and so that corroborates the idea that the LES and the diaphragm are lined up appropriately. In the situation where you have a hiatal hernia, the gastroesophageal junction is actually located above the diaphragm, above the esophageal hiatus. And so you should see two different points of high pressure, or this dual high pressure zone. One where the LES is pressing on the manometry catheter, and then one where the diaphragm is pressing on it. And that's represented in the manometry below that image, where you have the lower esophageal sphincter cruising along here at its resting pressure, and then with the initiation of the swallow, you have relaxation. Just below that, you have to see these points of high pressure. That's the diaphragm. And so this dual high pressure zone is seeing two different points of pressure, essentially at the gastroesophageal junction region. So you'll frequently see that. And we comment on that in our reports as well, saying likely or possible hiatal hernia secondary to the visualized dual high pressure zone. So that's the lower esophageal sphincter. Now I want to transition into the manometry of the esophageal body, and there's three different pieces of information that you need to understand, again, to come up with a diagnosis based on the Chicago classification. So the first is the distal contractile integral. In its basic form, this is just how strongly does the esophagus contract in the lower portion of the esophageal body. It has this funky unit of millimeters of mercury per centimeter per second, and that just comes with the calculation that's performed by the computer program, by the Manometry software program. You basically have four different types of swallows based on the DCI. They can be either failed, weak, normal, or hypercontractile, based on essentially how strongly the esophagus is contracting. Graphically, these are represented here with failed, weak, normal, and hypercontractile swallows. All of these are essentially peristaltic. I mean, even though technically in the failed swallow, you can't really say it's a failed swallow, so you can't really say it's peristaltic, but you can see that there is some element of peristalsis here. There's not any, it's not absent contractility. You do see a little bit of contractility in a peristaltic pattern, but these are the four different types of swallows based on the DCI. The second concept to understand from the esophageal body is this concept of distal latency. This is the time that it takes from the initial initiation of a swallow to a slowing point in the peristaltic wave, or what we call a contractile deceleration point. To show you what that looks like and what I mean by the contractile deceleration point, normal peristaltic swallow on the left side of the screen, you see there's actually two different phases of the swallow. There's sort of a rapid progression phase, and then a slowing of the peristalsis as it gets closer to the gastroesophageal junction. And the point at which it goes from that rapid progression to the slowing of the peristaltic wave is the CDI, CDP, the contractile deceleration point. The time that it takes from the initial initiation of the swallow to that CDP is the distal latency. So it's a measurement of time. This one on the left is actually normal. On the right side of the screen, there's it's premature contraction. It's 4 seconds, so normal is 4.5 seconds or longer. And you can see the scales are slightly different. That's why they look a little, you can't really compare the left and the right, but on the right, there's a premature swallow. Probably the most common error in automated measurement of an esophageal manometry study that I see is the measurement of distal latency, because the program will frequently measure that CDP incorrectly. So here you have a panesophageal pressurization where you have a fluid bolus against the non-relaxed LES. And so it can measure it to here, it can measure it to this point, where the CDP is actually way out here. So frequently you'll see that distal latency is actually measured to be too short by the computer program. And so this underscores the importance of having a human actually go through and read these studies and confirm that the reports are correct and adjusting things appropriate if they're incorrect. You can do that in the program, but basically I'll show how this can happen. So here's an initiation of a swallow. The peristalsis comes down here. The computer program actually incorrectly measured the distal latency from the second initiated swallow here. And so we ended up having to move this back to this point as demonstrated here. So it takes the distal latency from a negative value of 4 point whatever seconds to its actual normal value of 7 seconds. The other important point to make is the contractile deceleration point needs to be within 3 centimeters of the lower esophageal sphincter. And so frequently it'll be measured too high. Here we ended up moving this down a little bit to the appropriate location. The third and final piece of information that you need to understand about the esophageal body is fragmented peristalsis. So this is a disorder of the esophageal body transition zone. So what you'll notice in even a normal peristaltic swallow is that you have a proximal segment of the esophageal manometry study in the esophageal body and then a distal segment here. The reason that you have this center of transition zone is that it transitions from normal striated esophageal muscle down to the smooth muscle portion of the esophagus. And so you end up with a slightly lower pressure zone here at that transition zone. When that zone, that transition zone becomes greater than 5 centimeters in length, that's a fragmented swallow. So here, the zone of transition is 8 centimeters in length. And so that corresponds or designates a fragmented peristaltic swallow. So again, 4 main concepts that you need to understand to be able to come up with those diagnoses using the Chicago classification. The integral relaxation pressure, which is how well the lower esophageal sphincter relaxes during a swallow. And then the 3 concepts from the esophageal body: distal contractile integral, or how strongly the esophagus contracts; distal latency, or how quickly the esophagus, the swallow is propagated throughout the esophagus; and then fragmentation, having to do with that zone of transition between striated and smooth muscle in the esophagus. And with those 4 main pieces of information, you can essentially make all these diagnoses. So I want to transition. I'm going to see if I can transition. Can you guys see this on the screen? Andy, are you able to see the high resolution manometry study report?
No, I still see your PowerPoint.
Okay, let me see if I can.
You might have to hit stop sharing and then share the correct window.
Perfect. Okay, so that should
see it
now a Word document. Okay, great. So I thought I'd show just what one of these reports looks like once it's completed and printed. So this is from the Given technology system, one of the 2 systems that we use at University of Washington, and this is the printout. So on the first page, in the top left-hand corner, you have a graphical representation of a composite graphical representation of all 10 swallows that were performed during the study. And then you have a breakdown of pressure based on the upper and lower esophageal sphincters, resting pressure, motility down in the bottom left, and then residual pressures for both the upper esophageal sphincter and the lower esophageal sphincter on the right. The next page gives you more detailed information about the LES and the motility, as well as the upper esophageal sphincter. And then the following 2 pages give you graphical representations of each swallow. So both, so the landmark, which is just the patient at rest, and showing the UES and the LES, and then each individual swallow and what it looks like. And what I would say is that this is really important information to have. So we, in our reports, when we send them to the referring physician or the primary care physician, or both, if they're different people, we like to include all of this information in those reports when we send it. We don't just send a brief summary based on our interpretation of the data, because it is really helpful for, particularly I think for surgeons to look at this, but also for gastroenterologists and other referring physicians to actually look at this full report to have an idea about what do the swallows actually look like, and then what is the individual data points that we're using to come up with our diagnoses. And then the final page is the information for the Chicago classification, including the distal contractile integral for each swallow, as well as for the group as a whole. So I thought I'd just show that as an example of a report. I have a couple other slides and then I'll be done. I know I'm running a little bit over time here, but so a few things you might see. Alex has been keeping a nice library of common findings on esophageal manometry studies. So he was kind enough to share those with me. I have a few examples that he provided me. So one is coughing. So you see these high pressure panesophageal waves that come when a patient coughs. So it's just pressure exerted from the cough all the way down the manometry catheter. Another problem that can occur with the acquisition of a high-resolution manometry study is that the catheter actually loops within the esophagus, or it can actually even go into the stomach and then loop back up and go back into the esophagus. But that's represented graphically by this butterfly pattern or mirror image. So you can see how the swallow looks pretty normal, but then where you would expect it to be transitioning at the lower esophageal sphincter or gastroesophageal junction into the stomach, you have this backwards progressing high pressure wave, which is just essentially a mirror image of everything above this line here. And that's just that the catheter has become looped in the esophagus. Another example of that, again, this sort of butterfly image or mirror image that can be seen. So a couple of examples there, and I think that's where I'll end, but a couple examples of common sort of abnormalities in terms of the acquisition of the study. So with that, I'll stop my portion of the presentation. Andy, do we have any questions specifically related to what I discussed that you want to address now, or do you want to wait till the end?
Yeah, I think the next speakers are going to talk about some of the specific diagnoses, but I had a couple questions for you about the sort of operations of things. So first is, do you think that it's a viable part of a surgeon's practice to run their own motility lab? Does it pay for itself to do these studies?
I think it depends on the volume of studies that you're going to perform. Like anything, the more frequently you're doing these studies, the better, the more facile you're going to become, not only on the interpretation side, by looking at these studies and understanding variations that can occur and understanding how to interpret those variations and coming up with the diagnoses, but just like anything else in healthcare and medicine, but also actually on the actual acquisition side. So before we see these reports, there is a lot that goes into the actual acquisition of the data from the patient, right? Performing the study itself. And we, as you know, Andy, at University of Washington, we perform a very high volume of these studies. We perform a large number, like even maybe 1,000 or more a year. And so we have an esophageal function lab staff that are very well trained and can acquire this information very effectively. So there's a lot of points at which you can have variation from the beginning of the study to the end of the acquisition. And so if you're going to be doing, one a month or two a month, to be able to get, just like any other procedure, just to be able to get up to the point where you're able to do these studies effectively and consistently, it might take a really long period of time, or maybe you never ever get beyond that sort of learning curve. So I think it really comes down to the volume of studies that you're going to do, as well as your own personal interest and in terms of getting into it. Certainly the acquisition of the hardware and the software programs is a cost to consider. So there are barriers, I think, to entry in terms of doing these studies and setting up a lab. But I think if you're not going to do a high volume of these studies, partnering with a center or a team that does do a high volume number of studies and is well versed in that is probably a really good alternative option.
The reason I brought that up is that it's a pretty frequent question in the Facebook group. A person posts a case for comments, and they say they couldn't get manometry because their hospital didn't have it, or they didn't have manometry available. So that was the reasoning for asking the question. The other question I had for you before you move on, how often would you say that you have to adjust things like the location of the inflection point or the initiation of the swallow? Because one of the things that I see when I see reports that are sent in from elsewhere is often I disagree with the interpretation. And I think it's because the referring practice didn't take the time to change those parameters.
Yeah, so we will adjust those parameters with every single study that we do. So in the process of taking that raw data and putting it through the software program, for us, whether that's the Given system or the Sandhill system, the steps that you go through to then generate the report at the end, I will adjust that every single one that I read. So making sure that the upper esophageal sphincter marker is in the correct location, the LES marker is in the correct location, that your window for the LES is of appropriate location, as well as width or length, I guess, if you length along the esophagus. And then adjusting the pressure inversion point, as you mentioned. I mean, all of that, I don't know if I've ever read any study, and my guess is that all the fellows who have gone through our program and have read all these studies, I don't think there's probably a single study that's gone through where the computer program perfectly sets that up for you from the beginning. It's pretty good, but there's frequently adjustments that you need to make sure that you're getting the right data. Because for every one of those adjustments you make, that affects the data point or the pressure information that you get in the end, which obviously will affect your diagnoses that you generate from that report. So to your point, the programs are very good. And we've seen actually improvements in those over the last 5 to 7 years since I started doing this myself. But at the same time, I think having a physician or practitioner who's well versed in the interpretation of these studies to both perform the software program as well as look at the end results is important, because the results can be very misleading, as you mentioned, if you aren't looking over those yourself. And as you know, I mean, so we see the same general population of patients, and if the patient has had a manometry study done at another institution, as you mentioned, it's really important to make sure that you get that color final full printout that I showed, so that you can look through not just the diagnoses that are generated at the end, but also each individual swallow and all the data points to make sure that the diagnoses that are being given to you are actually correct. So if you're doing these studies yourself, it's important to make sure you're making the adjustments appropriately in the software programs. If you are having someone perform these studies for you at another institution or even within your institution, it's important to get the full reports and look over those to make sure the information is correct.
Great. And then had a question from Dr. El Hayek about EndoFlip and what you think the role of EndoFlip might be.
So I have not been using EndoFlip. I know that we actually just, I think, acquired it at University of Washington to use like in the last maybe 3 to 6 months or so. I think Brand Olschlager has used it. I don't know if you've used it, Andy, yet or not. So EndoFlip is a real-time esophageal manometry device that you can use actually in the operating room. They can give you information about the changes in pressure, if I understand it correctly, changes in pressure when you're doing an anti-reflux operation, perisophageal hiatal hernia repair, anti-reflux operation. And so you can see real-time changes in that pressure. It also, I believe, gives you circumferential information about pressure reading as well. While I think that preoperative esophageal manometry is essential if you're doing any anti-reflux surgery, I don't necessarily know that EndoFlip, I wouldn't say that EndoFlip is essential, but it certainly can give you information about what you're actually doing in the operating room as it relates to manometric pressure readings during your operation. What are your thoughts on that, Andy? Again, I haven't used it personally, so I can't comment from that standpoint.
Yeah, we've used it a few times in poems so that we can use it in the endo suite to make sure we have a complete myotomy. I'm not using it to guide my wrap, for example, in a routine Nissen, although I know folks that are doing it. For me, I think it's hard to put a interpretation on some of the values to know what values to shoot for. So I think it's one of those things we may be using it more in the future now that we have it and we can sort of learn how to use it. But for now, I see it mostly in doing poems. So, all right. So let's go ahead and move on to I think Alex, you're up next.
Hey, can you hear me?
Yep, we can hear you.
All right, let me share my screen now. All right, so let's dig into the subtypes of achalasia based on manometry. And so, I mean, what's going on? We used to just have achalasia. If you looked at the upper GI or your conventional manometry report, and all you saw was the failure of the LES to relax. And so that was achalasia, and you treat it in whatever way you would normally treat achalasia. But as Rob mentioned, sometime in the past 15 years, sorry, this is a conventional manometry, and this is somewhere in the past 15 years, high resolution manometry popped along, and you have these much more eloquent images to really look at esophageal motility. And so this is I think this is the first description of the types of achalasia not too long ago, 2012, but it really took off, and I think it really has guided how we counsel patients and how we treat them as of today. So this 2012 publication is actually the second version of the Chicago classification, and it classified achalasia into these three types. Now, before we dig into these types, just to add to what Rob said on the diagnosis, when I'm talking about manometry to anyone, I always make the analogy of imagine you're seeing toothpaste being squeezed out, and if you want to squeeze out all the toothpaste in one go, you'd probably start at the very top, work sequentially towards the bottom. But for that to happen, the cap needs to be off, right? If the cap isn't off, the toothpaste isn't going anywhere. So I think this is a nice analogy of what happens in achalasia. So type 1 is essentially no peristalsis. So you saw the scans Rob showed you. And here we see, well, this is the initiation of swallow 3. The upper esophageal sphincter and the cricopharyngeus is actually working fine. You know, it starts to swallow, but then nothing happens. Nothing happens in the esophageal body, and there is no relaxation at the LES. There's just the pressure is even maintained, and it actually goes a little bit back up, such as it will in a normal swallow. So no contraction, failure of relaxation in the LES is essentially a type 1. As with all manometries, you know, not everyone looks the same. So you have variations of this, but all you're going to see is no contractility. And for all the subtypes of achalasia, you always have this condition of having no normal motility during the study. So you never saw a normal swallow. So this applies to achalasia type 1, essentially a total failure of total aperistalsis of the esophageal body, coupled with a failure of the LES to relax. Sometimes you won't see the LES, and all you can really pick up is the aperistalsis, such as in this case. My gut feeling for this case, likely a sigmoid esophagus, likely the LES did not go through the LES. I'm sorry, likely the catheter didn't pass the LES, and it probably just coiled up somewhere in that sigmoid esophagus. So sometimes you'll see this, and you have to couple this with, you know, as radiologists say, clinical correlation is required. So this is certainly the case. A bunch of times in manometry, you will have to correlate with patient symptoms and other diagnostic studies like upper GI, EGD. But if you see this in a patient with dysphagia, most likely, you know, achalasia type 1, even though you couldn't really get a good sense of the LES here. So for type 1, what would I expect to see? Well, I think this slide was up before, sort of a sigmoid esophagus that empties slowly. And that's the radiologic image I would expect to see in a patient with achalasia type 1. Moving on to achalasia type 2, what you see here is, again, failure of the LES to relax. But in the esophageal body, there are a couple of spasms. And what do you call spasms? Well, look at how, remember Rob told you you have time on the x-axis. And so this contraction happened simultaneously. You know, the whole esophageal body from top to bottom contracted in a single moment. So that's an esophageal spasm, and we call this pan-esophageal pressurization. So when you see pan-esophageal pressurizations coupled with the failure of LES to relax, so that's when you have achalasia type 2. And the analogy I like to make here is, imagine you're just banging, punching that toothpaste with a cap on. So some of it will go up, some of it will go down. None will come out because, again, the cap is not off. And so this is not a very effective peristalsis, and the patient will have a pooling of whatever they swallowed in their esophagus. Again, multiple types of, you know, variation of the same thing. Here we have some higher pressure down at the LES coupled with the end of the contraction, and that's just how manometry is. Just like we're all different, you see different types of waveforms, but you take a good measure at the RP and look at that esophageal body, and you have your type 2 achalasia. Another variation on the same feature, actually, like some relaxation happened here, but likely not enough to call it normal. So again, classified as type 2 achalasia. I have a last image, and I really like this. this patient actually had, this is a post-op patient, not a myotomy post-op patient. This patient had a Nissen, and subsequently developed dysphagia. Dysphagia was not present in their preoperative assessment. They did have a normal manometry, but what happens if you close off if you take a rat and close off its esophagus, it will develop achalasia. So I guess you could call this pseudo achalasia, as it's not really an inherent problem of the nerve cells, but there is a distal obstruction. This Nissen is wrapped too tight, and it's causing these esophageal contractions. So the last type of achalasia, type 3. It kind of looks like type 2, but you don't have the pan-esophageal component. The swallow actually starts semi-normal looking, but then it moves on, and it will develop into this big spasm, hypercontractility at the lower end of the esophagus, coupled with a failure of the LES to relax. I like how the waveform moves up here at the LES. It kind of bumps, it contracts a little bit, and what you're seeing there are the longitudinal fibers of the esophagus that are shortening the esophagus during your swallow. But again, this failure of LES to relax, so you have your achalasia, just like before, different variations on the same phenomenon. Swallow starts semi-normally, and then just a big spasm with a failure of the LES to relax. So there you have it in a nutshell. Type 1, peristalsis. Type 2, pan-esophageal pressurizations. And type 3, what we call these premature contractions. A normal swallow that starts and then a spasm at the end. And so what differences what you expect to find? Well, probably if you were going to biopsy this esophagus or do an autopsy study on it, you'd find more loss of nerve cells in those myoteric plexus. For type 2 achalasia, clinically, you might find that they have a fair amount of weight loss. And importantly, type 3, these folks often have chest pain as one of their main complaints. Remember that type 3 is a rarest kind, so you're less likely to see patients with type 3 achalasia, but if you see enough achalasia patients, surely they're there. And does this matter at all? The pictures look pretty, but does this matter at all? I think it does. And there's some evidence to say it does. Importantly, for type 3 achalasia, as is the case with this patient, this is his upper GI. For type 3 achalasia, you might want to consider changing your approach, and if you have POEM available at your institution, POEM could be a good first-line option. The data is not 100% there. As you know, most data from achalasia comes from small series. I think the largest one is the Inuit's 500 patient series. More evidence is being gathered every day, I guess, and so we'll find out. But I think the consensus is that for type 3 achalasia, POEM is certainly a good alternative to surgical myotomy. And so this patient had type 3 achalasia, and that's the pre-op. And if you look at the post-op, it's really, I think this is the evidence for POEM, because you can really ablate that long segment of esophagus that was hypercontractile. Whether or not this really translates into better clinical outcomes, I think is still to be seen. But certainly within the Foregut community, we're more and more recommending POEM as a first line for type 3s. So I think that's it. Always remember, common denominator, type 1, non-relaxing LES, type 2, non-relaxing LES, type 3, non-relaxing LES. This is the common denominator for all achalasias. Remember, it's not a hypertensive LES. it's a non-relaxing. You can have a normal pressure, but if it's non-relaxing, I think this is the condition that really tells on achalasia. I think that's it.
That was fantastic, Alex. A number of folks in the comments are talking about pseudo-achalasia. Any pointers on looking at a manometry, how you can tell true achalasia from pseudo-achalasia? Or do you just have to go based on the clinical picture?
I think a clinical picture is very important. You can't miss it if you have, for example, rapid weight loss, any other concerning features that should prompt you to get a CT or an endoscopic ultrasound. Other than that, I think if you have subnormal peristalsis mixed in with any one of the features of pseudo, I'm sorry, of achalasia, sure, go look at that chart and make sure that this is not a case of pseudo-achalasia. I cannot remember seeing a pseudo-achalasia patient with type 1 achalasia. So my guess is that you'd probably see some features of spastic esophagus panesophageal pressurizations. And I think this is a good example of why you should get manometry beforehand, because what if you get a post-op manometry that looks like this and you didn't have one before, and now you're really in a bind. Like, does this patient have pseudo-achalasia from my rat being too tight, or did he have achalasia to begin with, right? So to your question, Andy, I think, again, a clinical chart and maybe look for normal peristalsis mixed in.
Great. I had a question from Dr. Puri about distinguishing type 3 achalasia versus a patient that might have esophageal gastric outlet obstruction with spasms, and if it's possible to tell that.
Yeah, it is. I think you need a good clinical eye. You have a very, a very good manometric eye. So that's why it's important to look at these with some regularity. If you are a Foregut surgeon, if you're doing interpreting these, it does become apparent. Certainly, you can have this kind of mixed picture, and you're not sure if it's truly achalasia. But I don't know what to say. It is a Gestalt thing. It's like you look at it and you kind of intuit that, yeah, this isn't really achalasia per se.
And then actually, Dr. Yates texted me a question for you to ask if you see changes in esophageal body contractility in type 1 and type 2 achalasia, like the picture you showed from type 3 achalasia.
No, I'd say you just see aperistalsis. You might see some sort of peristalsis mixed in there, some contractility. If you just have aperistalsis, but you find a single panesophageal contraction in the whole study, just one single panesophageal contraction, then that would prompt me to call the whole study just achalasia type 2. Even though most of it looked like type 1.
And then there was a question about the type 3 again. If you think you see any difference in the results between the dysphagia symptoms in comparison to the chest pain and spasm symptoms, do you find that they recover equally, or does one tend to do better than the other?
Definitely, chest pain is a harder symptom to treat. So again, this is why it's important to get these beforehand, and so you can counsel your patient. And that's just the way it is. Sorry to you'll just have to manage their expectations and saying your dysphagia will get much better, but you might still experience some chest pain, some chest spasms from time. From time to time.
Great. Well, let's go ahead and move on to the last speaker, Dr. Khaitan from Cleveland, who's going to talk about the non-achalasia esophageal motility disorders. And you're still muted, Lena.
me just bring up the slideshow here. So first of all, Andy, thank you so much for arranging this. And you know, the first two speakers, Rob and Alex, both did a phenomenal job. And I think the non-achalasia motility disorders are some of the most challenging to understand. And I think we're still learning that in the era of high resolution manometry. And so I'm going to give you, I think I'm the dinosaur in the group, and I'm going to give you a little bit more of a historical perspective, a little bit from traditional manometry, because I think that really helps us to understand high resolution manometry much better. So, so with that, we'll go over some of the signs and symptoms of some of these swallowing disorders, you know, a little bit about mechanical versus functional, and really spend most of the time on these non-achalasia motility disorders and the evaluation. Brief comments about treatment, but really Andy's running a group focusing on the management next week. So as Rob had pointed out, when we're looking at manometry, we care about the body, we care about the LES. And so he shared with you the key things that we get from high resolution manometry from the study, but when we're looking at the body from traditional manometry, we're looking at peristalsis and contraction amplitudes. When we evaluate the LES, we think about the length, how much of that sphincter is within the abdominal cavity, the pressure within the sphincter, and whether or not the sphincter relaxes. And if you think about these important aspects of the sphincter particularly, I pay more attention to that as I'm interpreting, and Alex and Rob both outlined that nicely, because as a surgeon, think about it, that's the only thing that we can really affect. We can't really do anything about the esophageal body so much. We don't have ways to make the body work better, but we do have ways in which we can alter the LES. High resolution manometry.
Lena, we can't see your slides right now, so were you trying to share your slides?
Okay, let me see. Let me see. Let's get back to this. Okay, I did share screen, and I clicked on this. Oh, I didn't hit share. Okay, are you seeing them now?
Yep, we see them perfectly. And the talk was great so far. I just wanted to make sure we could see what you're talking about.
Okay, and I'm going to go back to this. Okay, and you see the slideshow version now?
Yep.
Okay, great. So, so I think Rob included something like this in his talk, talking about the basics of esophageal motility interpretation. And high resolution manometry has really transformed what we can get from traditional manometry, and really helped us to evolve the interpretation of motility disorders. And if you think about it, the esophagus is still one of the least understood organs within the body, but we're learning more because of that, because now not only can we see pressures within the esophagus, but now we can also see whether they're effective in actually propelling a bolus through the esophagus, and that's what impedance is all about. So when we looked at traditional manometry, this is kind of how it all started, and you can see this is a traditional manometry in the bottom half, and we added in these impedance tracings, and you looked at your LES at the bottom, and this is really old school, and this is what they looked like a long time ago, and this is a far cry from what we can see now with high resolution manometry, where the high resolution almost mimics an esophagram. So you can either mirror the impedance on top of the manometry, like Rob showed us earlier, or you can kind of see them separately, where you have the impedance separated out from the traditional manometry to help us understand how the esophagus works even better. And when I think about non-achalasia motility disorders, it's where we really want to figure out various symptoms that our patient's going to come in with, right? And dysphagia is probably one of the biggest complaints we're going to hear about from our patients. And if it's not achalasia, well, then what is it? What's causing this for our patients? Taking a really thorough history liquids, solids, what brings it on, what are the foods that bother you. It's important to understand. And of course, that's going to be different from odynophagia, which is going to be different from chest pain. It's helpful if the patient tells you where they feel the food sticking, because again, that can help you correlate what we see on the manometry with what they're complaining of. And sometimes we might even see weight loss in our patients because of the dysphagia and the difficulties they're having swallowing. So, you know, causes of dysphagia can be mechanical, and I think that's very obvious. You can have strictures, and interestingly, we can actually see strictures on a manometric study, and they can be functional. And if we look at the motility disorders, we have motility disorders like achalasia, IEM, distal esophageal spasm, and nutcracker. We also have connective tissue disorders that will come across as a manometric abnormality, or we might even see manometric abnormalities due to underlying reflux disease that's affecting the function of the esophagus. So when we're looking at these studies, these are all the different things that we're trying to think about to correlate that with our patient's symptoms. So if I think back to traditional motility, and before we were able to bring the high resolution into it, and again, I think this historic information is really helpful to understanding how the Chicago classification and our current high resolution interpretation of studies has evolved, and this allows us to understand it better. So when we looked at traditional motility abnormalities, really what we had were diseases and patterns. And there were a couple of diseases that were very clearly seen on manometry, such as achalasia and scleroderma. And you could look at a manometry and say, yes, that's achalasia. Yes, that's scleroderma. And then we had a lot of other patterns, and these included nutcracker, hypertensive LES, distal esophageal spasm that we now call hypercontractility, and then IEM, or ineffective esophageal motility, which is kind of a grab bag when we can't explain a lot of other things. And if you take these into context, now we're learning a little bit more about how we can correlate these with the symptoms, but still thinking of them as diseases and patterns will help you to understand these studies more clearly. So if we looked at this is the first version of Chicago classification, and really taking into account the various parameters that Rob defined. IRP being one of the biggest things that we look at, and that helps us understand if there's some sort of outlet obstruction at the base of the esophagus. And then when you take that IRP, whether it's high or low, and then put that in context with intact versus weak peristalsis, then we start to get into these non-achalasia motility disorders. So this is where EGJ outflow obstruction was identified as a motility disorder that is separate from achalasia. So that not only will you see, you might see a non-relaxing LES with an elevated IRP, you're going to think more about a mechanical obstruction in these patients, although that's not always the case. It can also be functional. And they may have primary or secondary hypercontractility. So now we're getting a little bit more nuanced in our manometric interpretation. Similarly, if we go back to the IRP and we say we have a normal IRP and absent peristalsis, well, we call that absent peristalsis. But if the DCI is elevated, now we're starting to look at some hypercontractile disorders that might be correlated with spasm or chest pain. And then if some of the swallows have a reduced latency, or what we would have identified as simultaneous swallows on the on traditional manometry, that's what we call distal esophageal spasm. And finally, you can have a normal IRP and peristaltic abnormalities, including weak peristalsis or frequently failed peristalsis, and that takes us into another realm of interpretation. So, so the IRP is kind of the underlying thing that you're going to think about when you're looking at these non-achalasia disorders, and then correlate that with what the body's doing to distinguish that from achalasia. So if we look at some of the diseases, so achalasia, Alex reviewed very, very nicely. And as he pointed out, is that this is the big reason why we do manometry preoperatively, because you can, a patient can present with reflux type symptoms and actually have achalasia. And if you don't do manometry, you're not going to know the difference. And the last thing you want to do is wrap an achalasia. So that's probably, yeah, you know, that's my plug for always do a manometry. You're never going to regret doing a manometry. You'll only regret not doing one when you're trying to understand some type of foregut symptom. In scleroderma, again, one of the diseases that's identifiable from traditional manometry, the voluntary muscle has normal peristalsis, whereas the distal esophagus, or the non-voluntary portion of the esophagus, will have simultaneous swallows and generally of low amplitude within the esophagus and low LES pressure. And that's generally what scleroderma looks like. And of course, those patients are difficult to manage. You'll hear more about that next week, but you want to try to manage them medically as much as possible and approach any type of an anti-reflux procedure carefully. Now, if we move on to the patterns, you know, hypertensive LES is a very common one. You might see patients present with chest pain, sometimes with dysphagia, and manometrically, the LES pressure is going to be high, but their IRP is going to be normal. The LES will relax. Excuse me for 1 second. My son is in the background. Okay, I'm back. Generally, it's also going to be associated with normal peristalsis. And so a lot of times you're going to treat these patients medically. Again, the IRP may be in the 15 range, but usually it's going to show some relaxation. On traditional manometry, the definition would be an LES pressure mid-respiratory greater than 45 millimeters of mercury. Distal esophageal spasm, now we're still looking at this as a hypercontractile disorder, but also with high contraction amplitudes, but greater than 20% of those swallows are going to be simultaneous, but they are still going to maintain some peristalsis. Again, these patients, we're going to treat them medically the majority of the time, but some of them we may start to think more toward like an EGJ outflow obstruction, and a very careful history is what you're going to want to think about, but you definitely want to distinguish DES from EGJ outflow obstruction. The way you're going to do that is looking at that IRP. Operating on these patients is very, very difficult and very challenging, and setting patient expectations, as was discussed earlier, is the key when it comes to managing motility disorders. And this is what it looked like on a traditional manometry, where your impedance is going to be fairly normal, but in the distal esophagus, we're going to see some simultaneous swallows at least 20% of the time. Nutcracker esophagus has now been retermed jackhammer, but on traditional manometry, the distal contraction amplitudes are greater than 180. We generally see a distal ramping of pressure on traditional manometry with normal peristalsis. And again, this is of historic value, but on the high resolution manometry, you're also going to be able to see a little bit of that distal ramping of pressure, and I'll share that with you here in a moment. And this is, you can see that before the actual contraction happens, you're going to see a slow elevation in the pressure in the distal esophagus. And of course, Nutcracker, we treat the reflux, and the Nutcracker goes away. Like I said, ineffective esophageal motility is the grab bag still. Greater than 30% of the swallows have contraction amplitudes, less than 30 millimeters of mercury. We can see this in either a burnt out esophagus after years of reflux disease. Sometimes we've seen this post-Nissen. And if the patient has really bad esophagitis on an endoscopy that's active, you might also see this, excuse me, and it may be able to improve by treating the underlying inflammation. This is really a tough group to follow, manage. Chicago classification 3.0. You've seen this in one of the earlier talks, and this would be one to post on your, on your clipboard or something to keep in mind, because this is a really nice outline of now, where Chicago classification has evolved to, and it's a little bit more clear than the prior first version, and helps us to understand these motility disorders better than we did before. And as you look through this and you think about these abnormalities, it really helps you to understand correlation with patient symptoms much better. So this is a very nice paper by Marco Patti reviewing all of the non-achalasia motility disorders. You can see achalasia at the top of the screen, and then he separates them into major disorders of peristalsis and minor disorders of peristalsis. He'll go through these individually briefly here. The major peristaltic disorders include EGJ outflow obstruction, distal esophageal spasm, jackhammer, and absent peristalsis. EGJ outflow obstruction to me has been one of the most interesting things that we're able to see and understand now with high resolution manometry, which was a group of patients that was very, very hard to ever really diagnose, because you could see on traditional manometry some of that failure of the bolus to clear, but at the same time you might see some relaxation of the LES, you might see some maintained peristalsis. And so, these also often fall into that achalasia variant place. I'm seeing it more and more in my practice, and we're actually just doing a review of how these patients have been managed, because you try to correlate them closely with the patient's symptoms. They talk about feeling like food is sticking. You see the peristalsis intact. So you're like, well, maybe I'll treat the reflux, but what we're seeing in our current review, and hopefully we'll be completing that soon, is that you almost want to treat them more like an achalasia patient, because an EGJ outflow obstruction means there's something going on in the distal esophagus where the esophagus is not clearing well. And so I'm starting to be a little bit more aggressive with a myotomy in this group, but I'll be curious to hear what they discuss in the talk next week. Jackhammer esophagus is essentially one of the new names for nutcracker, and you can see with jackhammer that you're going to have normal relaxation. Your IRP is going to be fine, but your DCI is going to be elevated at least 20% of your swallows, and the DL is going to be normal, meaning that you maintain your normal peristalsis. So generally, I'm going to treat these patients like I would a patient who has gastroesophageal reflux disease. Distal esophageal spasm. Okay, these are patients who have premature contractions, or also look more like simultaneous type swallows, and this is going to happen at least 20% of the time. These patients still have the most common presenting symptom of chest pain, and so again, I think it's sometimes challenging to distinguish these patients from EGJ outflow obstruction. You can see in this example here, there is LES relaxation, but then the next swallow, you might see a little bit of pressurization within the esophagus. So very important to take a very thorough history in the patients as you're trying to figure out management. And again, a tough group to manage. If we go to some of the more minor disorders of peristalsis, a lot of times I'll see these going with reflux disease. These are the things that we're going to see from years of reflux, the esophagus being pounded on by the acid, and so it's going to lead to the esophagus not working well, and result in either some ineffective motility. And you can see that in this particular example, the patient has a hypotensive LES. You can see that they have 2 areas of pressure. There's a hiatal hernia there, and probably reflux might be leading to some of their problems. Or you might see some fragmented peristalsis, again, indicating a portion of the esophagus isn't working really well. And then absent contractility is this patient where you have complete aperistalsis. And these are usually where I see end-stage reflux disease patients. But you do want to make sure that you aren't missing an achalasia. Make sure that the catheter has generally gone across the LES, and that you don't say that they have kind of a burnt out esophagus mistakenly because the catheter never traversed the LES. Ineffective esophageal motility, now within Chicago classification, as I mentioned, is failed or weak peristalsis in at least 30% of the swallows. Again, this patient has a hypotensive LES, a hiatal hernia, and probably has IEM as a result of GERD. I think one of the things that I think is very interesting about ineffective esophageal motility in this example here, you can see here's a swallow that's not transmitted, and with the impedance, you can see that the bolus doesn't necessarily go through, and then the patient's able to generate a contractile swallow, but then the bolus clears, and sometimes, oftentimes, I'll even see IEM that I'll see normal peristalsis with waves that look like this, but very poor esophageal clearance where the swallow is not actually clearing the bolus. And so, you know, I'll interpret that as ineffective esophageal motility by impedance. And so that's also something that's a newer concept with high resolution manometry, and combining that with impedance that allows us to understand some dysphagia in our patients. And then fragmented peristalsis was pointed out earlier in one of the earlier talks. Just wanted to share with you a couple of sample tracings after prior surgery. Cough is something that I think we're understanding more and more because of high resolution manometry. Oftentimes I'm seeing it associated with poor esophageal clearance, and even in EGJ outflow obstruction, I'm noticing that more of those patients are presenting with a cough symptom, and you might see that even after LES augmentation with a Lynx device or a tight Nissen. And so this is a patient of mine who had a sleeve, came in with complaints of reflux. You can see every swallow is a double swallow. You can see that the patient has ineffective esophageal motility. The esophagus does not work very well. You can see that the LES does show relaxation, and in fact, this patient's IRP was marginal, and so we ended up converting this patient to a bypass. This was another patient after sleep who complained of choking at night, and so again, with high resolution manometry, we can see cool things like if you see this high pressure area between the LES and the esophageal hiatus, you can imagine that a patient swallows, food kind of sticks in here, and they have kind of an hourglass effect where food has to go through the LES and then through the hiatus. And this patient has a hypotensive LES. And down here, we don't see any pressure within the sleeve. This patient I managed with LES augmentation with a Lynx and hiatal hernia repair, and their symptoms actually improved significantly. And then this is a patient after sleeve with, I can see this better with the Sandhill system than the Gibbon system, but if you see this high pressure area, it's been a correlate for high pressure within the sleeve that I think even though this patient has a marginal pressure LES and a hiatal hernia, that even if I just fix the LES and the hernia, the high pressure in the sleeve won't be able to be overcome just by fixing that hiatal hernia, and so converting to a bypass might be a better way to manage. So this patient also presented with severe reflux, worse at night, worse after eating, and conversion made the symptoms go away completely. So, so that's a brief review of non-achalasia motility disorders. I think there's a lot for us to learn here, and I think we're understanding more and more, and I'll be happy to take any questions.
Great. So there were a few things that popped up in the comments while you were talking. There were a lot of questions about diffuse esophageal spasm and potentially the role of POEM, and wondering if you have any experience or thoughts about that.
Yeah, so the experience with that, so my partner, Jeff Marks, does most of the all the POEMs at our institution, the majority of them. And I'm lucky to have Jeff as a partner. And so he has done some POEMs in this group of patients, but I think just as when we had nothing better than traditional manometry, these patients are just as challenging. And so we don't have any definitive data. People are trying it, but I don't know, so far it's not something that Jeff's like, okay, let's do this for every single patient. He approaches it with some trepidation, but when it comes to a procedure, that's one of the few things we have to offer these patients if you can't manage them medically.
Yeah, I think similar to type 3 achalasia, I think sometimes the myotomy is better for dysphagia symptoms than it is for the spasm.
Yes.
And I think that's true whether it's a laparoscopic or an endoscopic myotomy. The only difference maybe the POEM could be a little bit longer myotomy than the traditional lapeller.
Sure.
I want to actually go ahead and bring in Alex and Rob. We can all sort of talk about this because there were a lot of questions about about esophageal gastric outlet obstruction and when that's meaningful and can be considered like a subtype of achalasia, when it might be secondary to, for example, a paraesophageal hernia or a prior Nissen, and when it's absolutely just meaningless and one of those things that we see because we do high resolution manometry and pick up a lot more stuff. Lena, you want to tackle how do you decide what to do about esophageal gastric outlet obstruction?
I mean, it's something that has been an evolution, and I think as we speak, I feel like my practice is changing because even I think Rob asked me, even if you see a normal upper GI study and you see the contrast pass through and the pill go through, but the manometry shows EGJ outflow obstruction, I think the key is correlating that with the patient's symptoms and asking them, what is really bothering you? And if they tell you their primary issue is reflux, then I'll probably err on treating the reflux. But if a couple times I've started to manage some of these patients with a myotomy and a toupee, I've actually gotten better results. So I'm starting to be a little bit more aggressive that way. And I think the manometry tells us a lot, but I really want to make sure that that patient tells me that they feel like food's not going down well. If they tell me that reflux or heartburn is their primary issue, then I definitely wouldn't entertain the myotomy, but I'm less likely to do a Nissen to treat their reflux if I see EGJ outflow obstruction on the manometry. Now, if they have a paraesophageal hernia, I say, well, that's the paraesophageal hernia. That's a different group of patients, but for patients with no obvious para, and I see that EGJ outflow obstruction and they complain of any aspect of dysphagia, I've been doing a myotomy with a toupee, and that seems to be working better than just trying to treat the reflux alone, which was actually the initial reason why they came in.
And any thoughts, Rob or Alex?
Yeah, I mean, one of the things I kept on thinking about, especially during your presentation, Lena, is the reason that I enjoy this area of gastrointestinal surgery so much is that it's not just, hey, and I'm going to probably oversimplify something that I don't do, but say with colon cancer, hey, you've got a colon cancer in the right colon, it needs to be removed, right? And I think with benign gastroesophageal disease, and obviously, again, I'm not saying that colorectal disease or colon cancer is straightforward in all cases. But in benign gastroesophageal disease, I think that there's a lot of nuances, and you can't take a single finding on an esophageal manometry study and say, in every single case I do this, or every single case I do that, especially in isolation, not knowing the patient's symptoms, not knowing what's on the upper gastrointestinal series, not knowing what's on their EGD, and not knowing what their pH study is like. And so, and even if you have all the objective information, if the patient's totally asymptomatic and it's a benign condition, do they need anything done at all? So I talk with residents a lot about this in clinic, when sometimes maybe they'll jump into wanting to do something or not do something, but have forgotten to take into account all of this information in their clinical decision making. So, and I think EGJ outflow obstruction is sort of the epitome of this situation, as basically you were describing, Lena. You know, in certain cases, you can probably completely ignore it entirely and it doesn't make any bit of difference. In other cases, it may be the underlying or the underpinning of a diagnosis of achalasia. And so one of the things that I've seen, you know, is if, Andy, you know, if the residual pressure of the IRP is 0.1 millimeter of mercury above the normal, technically that's abnormal. Technically that's an esophageal gastric junction outlet obstruction. But clinically, does that make any bit of difference? And when we're reviewing these studies in isolation, for example, in the lab, when we're reviewing study, patients get referred in, they're not necessarily our patients, and we're reading these studies, I have to interpret the manometric data that's in front of me, and our fellows do the exact same thing, right? And so it's important to report what you're seeing on the manometry study itself. But when you're evaluating a patient and the esophageal manometry study is just one piece of information you have, it's incredibly important. It's absolutely essential that you're taking that information in the context of not just the patient's symptoms and the patient who's sitting in front of you, but the other studies that you've performed or the patient has undergone as well. So long-winded answer to say it really just depends, right? I think a lot of these EGJ outflow obstructions can be ignored and probably don't mean anything. But it's maybe that's partly my impression because I'm reviewing most of these studies in isolation in a vacuum, not necessarily knowing the patient's symptoms and their other studies.
Yeah, I think you make a really, really great point, Rob, is that, you know, if you're going to manage foregut disease, you know, first of all, this is one of the few areas in surgery where we are trying to recreate functional anatomy. Pretty much everything else is kind of, you know, you see a tumor, you take it out, you see a bad gallbladder, you remove it. And like you said, not to simplify or discount the challenges within those disease processes, but more so to say that also setting patient expectation when you're trying to recreate functional anatomy is key, because a lot of it isn't straightforward. A lot of these patients do have nuanced conditions. You know, you do not want to alter this anatomy without having manometry, an endoscopy, an esophagram, and the pH study may be something plus minus, and then even a gastric emptying study. You know, you definitely want to have a full evaluation because you might see a hiatal hernia on one of those things. Like, I feel like I manometrically identify way more hiatal hernias than people ever see on a lot of other studies, you know, and so putting all those in context of the patient's symptoms, you really need to bring it all together. And then even then, sometimes it's not straightforward. There's not a cookbook for every single one of these things, particularly the non-achalasia motility disorders, because those are the ones where you really have to kind of take into account those nuances and how they correlate with the symptoms, because again, it's all about how the patient feels, and you're trying to recreate functional anatomy.
So there are
I'd just like to add, if
oh, sorry, Alex, go ahead.
on EGJ-00, if you have a patient that turns out to have it and you weren't really expecting it and now you're not sure what to do, you're not alone. Having been on this group, having gone to SAGES the past few years, this is a common question. It always pops up. And so just like Rob and Dr. Khaitan just said, you just have to go with it with everything else. But yeah, the EGJ00 is one of those things that I'm not sure if it should or could be revised in a future Chicago classification, because I think it does create some complicated scenarios in terms of surgical decision making.
So fantastic talks by all three of you. There are actually a few more questions on the comments on the live stream. I think it's fantastic. We've had anywhere between 30 and 50 people stick with us the whole time on a Sunday afternoon, and I think more people will watch this, over the coming weeks. Thank you all three of you. Because we've already been going for an hour and a half, I'm going to cut it short here, but feel free to join the comments and answer some of these questions. For anybody still watching, I do want to point out tomorrow, that's the 6th of April at 8 p.m. Eastern, on the colorectal group, they're going to be doing a talk on the MIS surgery in the era of COVID-19. The Facebook Foregut group has a number of talks, basically one planned every week for the next month, including talks on technical pearls and foregut surgery, a whole session on achalasia where they're going to debate Heller versus Poem, and also management of complications after myotomy. So we have some really great sessions coming up. So stick around, and hope folks can join the rest of our educational sessions on Facebook.
Thanks, Andy.
Thanks, everyone.
Thanks.
Thanks, Sandy.